I'm Dr. Peter Friedmann, Associate Dean for Research at the University of Massachusetts Medical School, Baystate, and President-elect of the Massachusetts Society of Addiction Medicine. And it is my honor to welcome you to Baystate Medical Center and to tonight's program, Reducing Opioid Overdose Deaths, What Works? So I'm going to be discussing first a little bit where we are in the epidemic, some of the proximate causes and epidemiology of opioid overdose mortality. But before we start, some quick definitions. So we're going to hear the terms opioid and opiate sort of thrown around tonight, and we want to be clear about what we're talking about. The term opioid actually is often used as a more general term. It includes both opiates, which are naturally occurring. They come from Papaver somniferum, the poppy, right, the flower of joy. And here is the fertilized seed pod that is being sliced, and the sap is opium. And there are hundreds of psychoactive compounds in opium that can be processed into opiates. Opioids, again, is the more general term, but it's also the term used for compounds that are synthesized. The example here is fentanyl, and we're going to be speaking a lot about fentanyl tonight, and carfentanil. Fentanyl is 50 to 100 times more powerful than morphine, which is a naturally occurring opiate, and is the precursor for heroin. Heroin is a synthetic. It's actually a semi-synthetic. And then there is carfentanil, which is even 100 times stronger than fentanyl, and unfortunately that is on its way, and we should not be sanguine about the improvements we've seen in the last few months in this area. So I will generally use the term opioid, but just so you know, I'm using it in the more general sense. All opioids share the characteristic of activating the mu-opiate receptor. The mu-opiate receptor is present throughout your body, but particularly tonight we are thinking about it in reference to the pleasure centers in the brain. And when a full agonist, and we're going to use that term tonight, binds and it fully activates the receptor. So there's the concept of the compound binding to the receptor, and then there's the concept of it activating the receptor. And what happens is you have a full agonist. This is the amount of activity. So if you will, how much pain relief you get, how much euphoria you get, depending on the rapidity, how rapid the onset is. And what you see is a full agonist is close to 100%. So typically, those are the most reinforcing substances. Those are the ones that are most liable to misuse. So heroin, morphine, oxycodone fall into that category. We also have partial agonists. And the partial agonist binds and activates to a ceiling. So what you see here is it's only, and this is just for demonstration purposes, but you see at low doses, you get a little bit of increase in activity at the receptor, and then it levels off. And that makes it safer. And an example of a partial agonist that we're going to hear about tonight is buprenorphine. And buprenorphine is a synthetic. It is actually a semi-synthetic. It starts with thebaine, which is a opiate, a naturally occurring opiate, which is synthesized into buprenorphine. That is the active ingredient in Suboxone or Subutex, a lot of the medications that we use. And then finally, you'll hear a little later about antagonists. Antagonists are not considered opioids. They purely bind, but they don't activate. And you can see that here. So it's bound. There is no euphoria. There is no pain relief. Any symptoms that folks have related to that are not improved with the antagonist. And you'll hear about antagonists tonight. We will hear about naloxone, which is the reversal agent for opiate overdose. We will also hear about naltrexone, not to be confused, but they're both antagonists. Naltrexone is commonly used for treatment, typically in a long-acting injectable form. Anybody know who this guy is? Who said Skinner? Raise your hand. Oh, you get an A. That is B.F. Skinner, the father, if you will, of modern behaviorism in the United States. And we can set up an experiment in which we put a rat in a cage, we put an IV in him, and he has an IV syringe attached to it that has, say, morphine in it. And we just turn him loose in the cage, and he kind of runs around like crazy, running around. And by accident, he hits this lever, right? And then he gets a shot of the morphine, and then he goes, that feels good, right? Right? He feels the reward. And that reward, he learns, right? And he learns in a very, very profound way. He learns, oh, if I do this behavior, I will get a reward. So what happens next? He hits it again, right? And he gets it again. So he has learned that if I do this behavior, I will get the reward. And that's in essence how, when he jumped in the cage, he didn't really know sort of what, and he didn't say, oh, I'm going to get myself hooked on morphine. He was just sort of running around randomly, and it was sort of set up for him like that. We can also set up the experiment. This is, by the way, this is an example of positive reinforcement, a classical, an example of operant conditioning. We could also set up the experiment that, we ring a bell, like Pavlov did. I ring a bell every time he hits the lever, and then if I just, he would get the feeling of pleasure and get the craving. Pavlov did it with dogs, right, with salivation, when he would put food in front of them, and he would just ring the bell, and then they would start to salivate. And that's the notion that there are associations with the reinforcement, the food, in the case of, anyone ever trained a dog with food? Anyone ever used a treat to train a dog? So the reinforcing of the ringing of the behavior becomes associated with that reward. The dog starts to salivate. And that's sort of how folks, when they're put back in their environment, experience craving, right? In AA, they talk about people, places, and things. These are associations that folks have with use, but it's not like associations like cognitive associations. These are very profound, conditioned associations that folks have. We could set up this experiment differently. Here's a rat on the cage who there's an electrified grid on the bottom, right? And if I set up the experiment such that if he runs around like crazy and he by accident hits the lever and he gets a shock, he learns, don't touch that lever, right? It's like why we know not to, when we're cooking, we put a glove on, right? We know not to touch the stove because at some point in the past we learned that's really an aversive. But the other way we could set up the experiment is to demonstrate negative reinforcement. And negative reinforcement is a really important concept here. And the way we could do that is if I turn on the electric grid and I turn it on and he's dancing, right? He's like, and he's going crazy around the cage, and then he hits the lever and the electric shocks go away, right? And then I turn it on again and he learns, oh, if I hit that lever over there, the electric shocks will go away, right? That's what negative reinforcement is. And that's a very important concept in this disorder because opioid withdrawal is an extremely powerful negative reinforcer. We're going to talk about that in a few minutes. If you're exposed chronically to reinforcing substances, there are chronic changes to your brain circuitry, two areas of the brain that affect reward and motivation. For those of you who are neurophysiologically minded, the nucleus accumbens and the ventral tegmental area, we could go through that. There will be a quiz later about this. However, suffice it to say, these are areas of the brain that are really essential to human survival. Well, not just human, but all animal survival, right? By the way, this is a sideways view of my brain, right? If I took a chainsaw and would like this, you would be looking at me sideways. This would be your spinal cord coming down here. And these are the really central parts of the brain that we all have, and really all animals have as well. These are very primitive parts of the brain. And then we have this neocortex, which is relatively new in evolution. So these areas that affect reward and motivation are really profoundly affected. Areas that affect conditioned learning, which we just talked about, memory, and emotion. So your whole limbic system that affects emotion is also right there and affected by this. And then it also affects parts of the brain that influence what's called executive functioning, decision making. So this disease affects all of those parts of the brain, and unfortunately those changes, the term I use is they're semi-permanent, and there are some people who contend that they really are permanent. Certainly the memories and conditioned responses are permanent. It's sort of like, I don't know how many of you have ever, I don't know, well, you had Thanksgiving recently, right? You had a smell and it made you think of a parent or someplace you were in the past, right? Very profound emotions tied up with conditioning and very, very long lasting. And this explains the syndrome that we see in addiction. And I use the term addiction synonymously with what the DSM-5, which is the Diagnostic and Statistical Manual, that's the manual that psychiatrists use to define all the diagnoses, all the mental health diagnoses. And I use it similarly the way that substance use disorder, moderate to severe, is used. And there is a characteristic of the disease of compulsive use, the 4 C's: impaired control, continued use despite consequences, and craving. And those are the things we see in people who end up having this disorder. And unfortunately, those are long-lasting and difficult to change. And all of you know behavior is difficult to change, because I'm sure all of you have tried to change a behavior at one time or another. Anybody ever gone on a diet? Oh, you're all liars, every single one of you. Anybody ever tried to quit smoking? Anyone have thought to exercise more? Oh, well. Behavior is really hard, and going back to change behavior is really hard, and recurrence is really common. But when you think about these substances that really affect these very primitive parts of the brain, it becomes extremely difficult. Which sort of brings me to the point that addiction is not the same thing as dependence, and people often confuse those. Physiologic dependence is a normal response to appropriate use of many medications, including opioids. So you'll see people who are on chronic opioids for pain, taking it perfectly appropriately. If I were to suddenly cut them off, they would experience withdrawal, they would experience, they would be very unhappy with me is what they would be. But this is a normal response. It's not to be confused with addiction. However, the physiologic dependence on opioids does explain some of what we see in the syndrome. And there's a very important concept that I hope you'll come away with, is the notion of tolerance. And tolerance is seen with physiologic dependence, and what that is that as you use the substance chronically, you have a decreased effect over time. So you need more and more and more and more in order to get high or relieve withdrawal or whatever the particular effect is over time. Yeah, and so we see patients who are taking doses of opioids that would kill you or me, right? We would overdose. But they tolerate because they've developed tolerance over many years. And the corollary of that is they need an increasing dose in order to achieve the same effect. This is an important concept because what we see in this disease, and inadvertently through some of our treatments, is we take people off their opioids. We detoxify them. We put them in abstinence-based treatment, and they lose their tolerance. Now, you remember a couple slides ago I told you that these changes in the brain are really long-lasting, right? And they go back to their environment, and the use recurs. Well, if they use at the usual dose, they've lost their tolerance, what's going to happen? They're going to overdose. I think this is a major part of what we're seeing Similarly, you know, folks would need to cut their dose in order to achieve the same effect, and some people can do that successfully. But the issue is, you know, a lot of, particularly the street opioids, you don't know what you're buying. You don't really know what the potency is. So I think this explains a lot of what we see in overdose. I mentioned withdrawal. It's a very powerful negative reinforcer. It is an excruciating syndrome. The way I like to describe it is, if you can imagine for a moment the worst flu you've ever had, right? You had a terrible flu, you know, your head is killing you, aches, sweats, feeling miserable, right? And then you add on top of it like the worst lower GI illness you've ever had at the same time. You have abdominal cramps and you feel, you know, diarrhea and you feel crappy. And the thing is, you have that knowledge that if I just take a little bit of opiate, it will all go away, right? So it's like the example of the rat that we showed on the grid. They know if I hit that lever, this feeling will all go away. And it is excruciating, and people, and we'll hopefully hear later, people spend their whole lives trying to avoid this feeling because it is awful. And it is a really powerful negative reinforcer. So I'm going to jump into the epi quickly here. So what we have seen between 2000 and 2015 is a dramatic increase in overdose deaths from any opioids. But interestingly, around 2009, 2010, there really was a flattening of prescriptions. So early in the 90s and 2000s, the epidemic maybe was explained by prescriptions. But what we're seeing now is prescribing has flattened or decreased slightly. And really now what we're seeing is that most of the deaths are from heroin or increasingly from other synthetics, particularly fentanyl, which is increasingly adulterated the street heroin supply. And that's certainly true here in Massachusetts. So this is from a New York Times article. About 20,000 of the approximately 58,000 deaths were from fentanyl and fentanyl analogs. And if you look at this figure over here, this is Massachusetts right here, and the light blue here is the proportion from fentanyl. In 2016, I believe it was about 67%. And currently, for the current year, it's about 81% of the deaths are explained by fentanyl. And we see similar trends in our sister states around New England, that the fentanyl really is driving the mortality. And even though we've seen in Massachusetts, you know, so this, and this is around the time that, you know, we started decreasing prescribing and people were moving over to street sources, and fentanyl sort of came onto the scene, and we saw this dramatic increase in overdose deaths. Now, in the first 3 quarters of this year, there has been reported a 10% decline, but my saying about this is, you know, carfentanil hasn't hit yet, and it's coming. I mean, so, you know, we certainly can't let up in terms of our efforts. I think this decline is really laudable, and frankly, I want to applaud our panelists because a lot of it is because of the hard work that they're doing, which we will hear about. So naloxone distribution, increasing access to effective medication, reaching people who are out of treatment, teaching folks how to use safely, et cetera. So this sort of shows the increasing red between 2011 and 2015. You can see here we are over here. There's sort of an increasing amount of red throughout the state, but in our region. So clearly, this was a very dramatic rise between 2011 and 2015. I'm hoping we've peaked, but I don't know. The other thing about the epidemic, and I alluded to this earlier, is that you know, back in the olden days, when I was a kid, before 1990, most folks who entered treatment for heroin in particular had started with heroin. But what happened and you heard about it, in the news, been very well described that in the 90s and through 2010, most folks started with prescription opioids, so that's what the clear dots show there. But prescribers clearly have responded, and since 2011, we've seen a 23% decrease in opioid prescribing in this country. So we're sort of back to the future. This is oxycodone and hydrocodone, the most common prescription opioids, and you can see that the rates of initiates with that is declining while heroin is increasing. And so now we're seeing more and more individuals who are starting with heroin, which has really been the traditional pattern of opiate use, and sort of explains a lot of what we're seeing in recent years. So what I want to emphasize, though, in terms of the proximate causes is that, we, and I say we for the medical professionals in this room like myself, we have clamped down on opioid prescribing since 2010, good for us. But the focus of our policy and practices has really been an abstinence focus, so people go to jail or prison where they're promptly detoxed. They go to detox programs, they go to medication-free treatment or abstinence-based treatment, and they lose their tolerance. So that's one option that folks have made available. And at the same time, we're seeing a wider distribution of illicit opioids, of increased availability, decreased price, and more heroin initiates. But we've not done enough to really improve access to effective medication for addiction treatment. We're going to hear more about that in about a minute from Dr. Roos. Suffice it to say, because we haven't done that, a lot of these folks go on into use the risky illicit opioid supply, which is of increasing potency, increasing variability in terms of the potency, particularly since it's been adulterated with fentanyl, and so that explains a lot of what we are seeing. So at each of these arrows, there are things that we could do to stem the tide, and we're going to hear a little bit about some of those things tonight. Just to put a final period on the notion that tolerance is really important, these are data from the Chapter 55 data, which is the state database in Massachusetts. And what we see after incarceration, where people are typically detoxified still in our state, although hopefully that will change soon, 120-fold increased risk of overdose after people with opiate use disorder leave prison compared to those without an incarceration history. Similarly, we see in pregnancy, so we've done a very, very good job of making sure that pregnant women get medication treatment, right? Because, and dare I say, it's not because we're so concerned about the women, we're concerned about the fetuses, right? Because promptly, as soon as they come off, most of them come off their medication or are encouraged to come off their medication. And so what we see here is dramatic increases in the death rates among women who, opiate-using women who've been after delivery. So I'm going to stop there. And I'm going to let Dr. Roos come up and tell you about the benefits of medication treatment of opioid use disorder.